And welcome to uh, the hip joint and pelvic girdle lecture. Today we're going to be looking at the difference between the hip joint and the pelvic girdle. When we look at the hip joint, specifically what we're really looking at is just the connection of the head of the femur with the acetabulum or the socket of the hip, and the pelvic girdle would be including both the left and the right pelvis. So one of the things that makes the hip joint or the acetabular femoral joint important is that it's relatively stable because it has a bony architecture. It definitely has a strong ligamentous support, and it really protects with excessive ranges of motion. So we don't really see ligamentous support until we see excessive ranges of motion occurring in the head of the femur with the acetabulum. It has extremely large supportive muscles, such as all of the glutes, glute medius, minimus, maximus. Its main job is in weight bearing and locomotion. It's enhanced significantly um, with its ability for its wide range of motion. So even though we look at the hip joint as being relatively mobile, it has very little stability. So when we look at the line, we can see where the hip joint, and again, when we're talking just about the hip joint, we're talking about this region right here. So we're talking about the head of the femur with the acetabulum of the socket of the pelvis. When we talk about the pelvic girdle, then there'll be relatively more stability added once we add the stability aspect of the pelvis. So in order, when we see the joints that are most mobile, we see the glenohumeral joint, the hip joint, the elbow joint, particularly because we see pronation and supination, and then the intervertebral joint. You can see the importance that we lose mobility, but we gain stability, and that's for protection of the spinal cord. And then again, as we go down the line, the sutures in the head of the skull, we also gain stability and we lack mobility for protection purposes. So when we're looking on this end of the fence, we're really looking at the mobility factor. We want to sacrifice the stability to make up for the amount of mobility. When we're looking at the ball and socket joint again, when we're looking just particularly at the hip joint, we're looking at this region here. So we have the head of the femur and the acetabulum of the pelvis. Some important areas that we should start incorporating is when we look at the pelvic girdle, we're going to incorporate a very unstable position. This is the posterior movement of the sacroiliac joint. This is going to be where we see displacements or differences, like when we did our postural assessment, we see postural differences in the overall height. So this is a joint that we can see the shifting between the left and the right pelvis. So the pelvis is three bones fused together, but they're independent when we look at the right side versus the left side. So when we start talking about the pelvic girdle, you want to be aware that they can articulate along these sacroiliac joints. And then any tightnesses that are occurring through the hip socket, what we can also see is some sort of deviation occurring through the pelvis. This is just a blown up version of the right femur. So we're looking at a posterior view of the right femur. Here we see the hyaline cartilage, which is important for articulation with the acetabulum. We'll see the same makeup with the hyaline cartilage on the inside of the acetabulum. We see a bony landmark called the greater trochanter, which is extremely important when we look at connections with the gluteus maximus. And then down here you can see where we again have the medial condyle and the lateral condyle, which is going to articulate with the tibial plateau. So when we're talking about the sacrum, we're really looking at 5 fused vertebrae. extending inferiorly as from the coccyx. So when we're looking at the sacrum, again, the sacrum is going to be this bony region right here minus the coccyx. And you'll see the most important aspect is going to be the sacrum is going to form the sacroiliac joint between the right and the left pelvis. We're also going to see in the next slide a series of foramen. These are important for nerves. At the top we have the ala, or the promontory. This is where L5 is going to sit. So we have the connection between L5 and the ala of the sacrum. We also have the foramen, where we're going to see different types of nerves that are going to project later on in a different lecture along that. The superior articulating surfaces, these surfaces are important. We see a lot of muscle attachments along it, especially when we look in the posterior view. So you can see the ridges that are formed. A lot of the glute musculature is going to connect here also. So when we're looking at the pelvic bone, you have to remember that during endochondral ossification that it was originally in 3 areas. So when we're looking at the differences, what we see is that first we're going to see the ischium, or the ilium, the ischium, and the pubis. So these 3 bones, when we see the convergence of these 3 bones, we're going to see that it actually compartmentalizes all the different aspects of the acetabular joint. This is going to play an important when we're talking later on about impingement factors. So here we have the ischium, here we have the pubis, and here we have the ilium, and all 3 of these bones are going to form some different aspect of the acetabulum. And this is going to play an important role of how the femur is actually going to sit. The head of the femur is going to sit inside of this acetabulum. When we talk about the full name, they call it in your book, it's called an os coxae. And an os coxae just means the adult fused version of the pelvis. So when we add all 3 areas, this is going to give the name of os coxae. When we're looking at bony landmarks, some particular areas that we're going to be interested in is the superior iliac spine. So we talked a lot about this in postural assessment. The iliac crest, or the anterior iliac crest, we see things like your tensor fasciae latae attached there, and your anterior inferior iliac spine. And this is where we see the 2-joint muscle of the rectus femoris attached. On the posterior surface, one of the things that we should be aware of is that all your hamstrings are going to attach in the ischial tuberosity. So when we're looking at the origins and insertions of all your hamstrings, we're going to see that all 3 are going to converge on your ischial tuberosity. We talked a little bit about the myofascial tissue, how we have the sacral tuberous ligament coming through. Once it reaches the middle of the sacrum, then we see the dorsal sacral ligament connecting here. So you can view the hamstrings as the insertion, or the origin, I'm sorry, attaches in the ischial tuberosity. But on a myofascial scale, we see that we have an extension going to the opposite hip, which we talked about in previous lectures. So the glute muscles, as I mentioned earlier, they're all going to connect into the greater trochanter. These are particularly important for all the external rotation of the hip joint. The iliopsoas is going to connect into the lesser tubercle or the lesser trochanter, and your iliopsoas is important for hip flexion. The hip adductors, the linea aspera, these are all going to connect on the medial surface. So when we're looking at adductor magnus, longus, and brevis, they're all going to connect onto the medial surface. One of the things that we should also mention is the pubic symphysis, or the symphysis of the pubis. This is going to be the arrangement of what we consider to be a fibrocartilage. Again, when we're talking about fibrocartilage, just making sure that you know that fibrocartilage is going to be it lacks an outer membrane. Its most important job is for shock absorption. So when we look at the SI joint here, even though we consider the pelvis the fusion of 3 bones that are going to help support the acetabellum or the acetabulum, then what we see is that the left and the right are going to be independent of each other. And any compression of movement, when we're looking at transverse rotations of the pelvis, we're going to see that this has the ability to be a shock absorber in the front. So when we're talking about movements, one of the reasons why we see that the hip joint, particularly the hip joint, is the ability for it to do multiple ranges of motion. One of the things that is not mentioned here is that you have the ability to do circumduction. So if I was to add one more to this list, it's the fact that your hip joint can do circumduction. And when we're looking at circumduction, circumduction is just the ability to move in a circular pattern. It is not considered to be a rotation because it's not specifically in one direction. So circumductions can be, bigger circles. It can be smaller circles. You can go even smaller. So a circumduction, it depends, and you can transfer into these. So you can start swinging your leg in a circular fashion, and you can go from a large circle to a smaller circle to a smaller to a smaller to a larger to a larger. That's what makes circumduction so interesting. Versus when we look at internal and external rotation of the hip, what we see is that internal rotation has a certain degrees that it works with, and so does internal rotation. So these are going to have, some sort of a degree or range of motion associated with it, where circumduction doesn't really have a range of motion associated with it. So that's primarily the major differences between circumduction and adduction or rotation. So when we look at the rotation, so pelvic rotation, we talked about this a little bit, is we only really see in walking about a 3 to 5 degree difference in walking. So you have a 3 to 5 degree difference with walking with a transverse rotation in the pelvis. You may have a 3 to 5 degree difference with a lateral tilt. So when we're talking about anterior versus posterior tilt, an anterior tilt would be when we extend the ischial tuberosity into the posterior compartment. When we're talking about a posterior tilt, we talked a little bit about this. This would be the bad dog. You're tucking your tail under. Lateral tilts, if I'm standing on my left leg and I raise my right foot off the ground, that would be a left lateral tilt, and a transverse tilt would be moving along the transverse plane. So one of the things that makes the acetabular femoral joint very rigid is the fact that it has the cartilage, or what we consider to be the labrum, the suction cup, which allows for the suction of the head of the femur to come in contact with the hip joint. We see very little subluxations. Subluxations are a partial dislocation, and when you're talking about a dislocation, that would mean that the head of the femur has completely come out of the socket. One of the things that's interesting when we look at the architecture is that 3/4 of the head of the femur is going to be situated inside of the socket of the acetabulum. So a subluxations, maybe you only move it out a little bit, very little damage would occur. When you're talking about dislocations, dislocations are usually associated with labrum tears, and labrums, again, are the suction cup that allow for the head of the femur to articulate with this. If we're also going to talk about another dysfunction, I would say the posterior impingement would be the biggest issue, and we see that because in the posterior aspect, we see how in the posterior position, we see that the head of the femur will become impinged, usually because of that external rotation of the hip during walking. As we go through the ranges of motion or the protection mechanism of the ligamentous system of the acetabulum femoral joint, what we see is that these are only going to prevent. So I stress that a lot. When we look at the anterior picture, we're looking at the iliofemoral. So the iliofemoral is actually a branching or a bifurcation of this ligament. So one goes closer to the lateral side, one goes closer to the medial side. And it's going to only fire when you go into a hyperextensive position. So if you were to slip and go into a splits, you would feel the iliofemoral ligament fire for protection. And when you feel your hip joint, you can see that the biggest area that we see with tightness that occur is usually in the front of the anterior position, like your hip flexors are coming through here. So we see here, your rectus femoris would come down, the origin. We see your sartorius coming down. So we have a lot of musculature systems that are going through this area. But the biggest protective and the strongest ligament out of all of them are going to be the iliofemoral ligament. Just erase these real quick. The next part, it would be the pubofemoral ligament. So you can see the pubofemoral ligament located here. This does excessive extension and abduction. So again, just to use the same skill as like if you were to do a split, this is what would be coming to come tight on you or would fire to protect. The teres ligament is actually pretty interesting. The teres ligament, it's also called a round ligament. This actually used to be an artery. So during endochondral ossification, this is what was bringing blood into the epiphysis. And then eventually what happens is this will eventually turn into a ligament. You don't really need a lot of protection for adduction. That's the most limiting aspect of the hip joint. Limiting adduction is not as great a risk. And also what limits adduction, if we go into the posterior compartment, would be the tightness in the posterior aspect of the hip joint. This one in the back, we see a big problem with limiting internal rotation. So when we're looking at the ischiofemoral ligament here, this one limits the ability for you to go duck-footed or bring your toe in. It limits internal rotation. And you have to remember all the deep external rotator muscles are all connecting, the 6 are going to connect into this greater trochanter. So one of the things that you have to ask yourself you know, is it going to be, more because of the deep six? So when we're looking at all the external rotators like quadratus femoris, superior inferior gemellus, glute minimus, is the tightness or limited internal rotation going to start with all the connection of the muscles, or is it going to be the ischiofemoral ligament that is tightened up because of this? Limiting internal rotation, this is probably the biggest deficiency that we see in people. Most people's internal rotations are usually commonly caused as a tight hip. So when we're talking about ranges of motion, there's a lot of disagreement when we're talking about ranges of motion, and it's particularly how you measure it. So when you're looking at keeping the hip joints or the pelvis stable, that's the most important aspect. So when we're measuring ranges of motion, particularly at the hip joint, we need to make sure that we stabilize the pelvis. If you do this in a standing position and try to make measurements, then you're going to find that the pelvis will be able to move to increase the hips ranges of motion. Probably the most important aspects of hip joint range of motion is going to be, at least bringing the top of the quad close to the bottom of the 12th rib. That's usually about 120 degrees. When you are testing someone, you want to make sure that you don't see the compensation occurring in their lower back, meaning that we shouldn't see any excessive arching. It's the same thing when we measure extension. We should see that you're able to raise the leg up 30 degrees off of the table, but we shouldn't see you excessively rolling the torso to one side. We shouldn't see a lot of activation in your lower back. So we should not see any tightnesses that are going to occur with extension. And a fixed position, if your hip joint is not mobile, we'll see you roll to one side, and we may also see compromised lower back. This one is just a different version. I prefer to use this one. We rarely test someone in this position. We tend to get more people who roll over on one side as far as their torso is concerned. When we look at ab and adduction, so abduction means that we're going to be rotating out about 45 degrees. Particularly what we will look at is the anterior superior iliac spines on the front of the pelvis, making sure that they stay along one plane. So you can see this line here at 90 degrees. We don't want to see them laterally shifting on the table. Adduction would require you here to raise the foot up, and you can see the difference between 20 degrees and 45 degrees. So there's a big difference between ab and adduction when we're measuring people. And finally, the big one, the internal versus external rotation. When we're looking at internal versus external rotation, the first thing to point out is most of us has a greater amount of external rotation versus internal rotation. If we're going to talk about dysfunction, you're always going to, most of the time, not always, you're always going to find dysfunction somewhere in the internal rotation. And again, this can also be because of the 6 external rotators of the hip joint. But one of the things that's most confusing on students is to remember how internal rotation works. I usually use the knee as the landmark. So if I move my foot out, my knee will travel in, and then therefore this would be considered an internal rotation. Using that same theory, if I move my foot into this direction, then my knee will want to travel out, which is considered to be external rotation. So using that same theory, when we come over to this next one, if I move my foot in this direction, laying on my stomach, my knee will move in, and that would be considered internal rotation. If I move my foot into this direction, then what we would see is that your knee would move out, and that would be considered external rotation. So I always teach it by the whole concept of the relationship of first trying not to put terminology on the foot. Just say, if I move my foot away from the midline, then what does my knee do? And that is internal rotation. So trying to only put the rotation aspect on what's occurring at the knee. If I move my foot towards the midline, my knee is going to move out or externally rotate. And it's a nice little trick to prevent confusion when you're testing. But again, I can't stress this enough. As long as we see the total internal and external rotation somewhere between 45 and 50 degrees. Thank you, and that ends part 1.